Dr. Adarsh, you can stop screen share. Dr. Adarsh, if you stop screen share, please.
I'll call him and say this.
Yeah, that's fine. I'll do it now. Namaskaram everyone, and welcome to today's webinar. Today's session is IAP Twin Cities branch postgraduate clinics. And at the outset, let me thank all the IAP TCP members and people who have joined from other branches as well, including the postgraduates, for supporting IAP Twin Cities branch in all its academic activities through the year. We have had a lot of hard work put into these sessions, and I'm very thankful that we have had good attendance and also the constant support from all of you. Thank you so much. I request you all to please register for the IAP PATS-IAP Annual Pedicon 2022. This is from 9th December to 11th of December. And we also have a sports fest with 8 sports being played on 4th of December, the next Sunday, and also the 9th of December on the day of the workshops after the workshops are over. Request you to please register for the sports activities, the workshops, and also actively participate in the annual conference. I now hand it over to Dr. Bhaskar, our president, to please take it forward.
Thank you, Dr. C. Krishna. Good morning, all. And at the outset, I thank Dr. Srinivas Medveli for coming forward to present a long case from his unit. As well, Dr. Ram Reddy, a senior professor of pediatrics at Karimnagar presently. Though he's occupied with his alumni get-together of his MBBS classmates at nearby Karimnagar. Despite that, out of his affection towards IAP TCB executive body, he had readily accepted and is participating from Karimnagar. Thankful to Dr. Ramesh Kananki, he is always a resourceful person for IAP Twin Cities branch, particularly to me. Thank you, sir. Despite being a Sunday, you had accepted and you are here very much. And really, these PG clinics, the 11th one in this year 2022. This is the 11th one we had done every month uninterruptedly. And it was possible mainly because of the academicians. So many academicians and so many children hospitals are there in Hyderabad. We are easily getting support from the academicians and experts as well. Amazingly, even the response from participants is so good, so encouraging that we are very, very enthusiastic to continue these programs. This is my last but one program of IAP TCB PG Clinics with the support of my IAP TCB Executive Board, particularly Dr. R.S. Sri Krishna. I'm getting tremendous support from him and we are able to do so many activities. So I thank you all for participating, and particularly this PG Clinics, I believe it's a real academic program, very useful to PG students, DNB residents, and as well people like me practicing pediatricians. With these few remarks, once again, I thank all the participants. My respects to seniors who are there, who have joined this PG Clinics. My pranams to them, because their presence gives us, boosts up our morals. So with these few words, I wish you all a great learning experience from our experts and from this long case. Amazingly, CNS case is always interesting for the presenter, for the mentor, and as well for the experts. So with these few remarks, I request you all to join, to participate, to register in our upcoming Iaptcb and Telangana State Annual Pediatric Conference, which is going to be held on December 10th and 11th. And another news, our senior residents, I'm sorry, our senior colleagues who are above 65 years of age, as per the certificates, they are welcome to join the conference on honorary complimentary basis. So I invite all the senior pediatricians above 65 years, please come and join us. It's a token of gratitude and respect towards the senior pediatricians. With these few remarks, now I request Dr. RSV or Dr. Srinivas Medveli to say a few words, and then let's have this Iaptcb PG Clinics. Dr. Srinivas? Yeah, Dr.
Yes,
Srinivas.
sir. Yes, sir. Yes, sir. First of all, I thank Iaptcb and Dr. Sumkoj Vatskar, sir, for giving this opportunity from us. I've been seeing sir from more than 4 to 5 years. He's because of sir, the academics in Hyderabad, and I say that Iaptcb was conducting. I even participated in so many academic sessions conducted by sir. It's really, really good to have such sessions in Hyderabad and from Telangana, because we are lacking from compared to other states. So I really appreciate sir and whoever attending this discussion. So I think I'll ask others to start the case discussion, sir.
Before that, we can ask our senior pediatrician, Professor Sridham Reddy, to say a few words from Karimnagar.
Yes, sir.
Unmute, sir. Unmute. Sridham, sir. Unmute cheyandi. In the meantime, I request our another expert, a leading pediatric neurologist from Rainbow, Vikrampuri, Dr. Ramesh Konanki, please say a few opening remarks, sir.
Good morning, sir. Good morning, everybody. It's always pleasure to teach postgraduates, because I think this is most gratifying out of all my clinical work and other than research work. All the best, all the exam going PGs, and thank Iaptcb to invite me for this session, and also for organizing postgraduate teaching. I think because of lack of faculty in many colleges, students are facing problems with the exam preparations. I think this is a great endeavor to help all exam going PGs. Thank you so much.
Thank you, sir. Mr. Anybody, sir? Okay, Dr. Srinivas sir will join us. There is some technical meantime, Srinivas, you can ask our friend, presenter, Dr. Adarsh.
Sir, I think we're getting some disturbance in your voice, sir.
Yeah.
I think it's better to mute all and unmute only others, sir.
Yeah, it's already enabled like that. Only the co-host can mute and unmute as well. I think the issue is with Adarsh, and that's why he's the one. I mean, his ID is the one who's getting the noise. Adarsh, could you please check once?
Good morning, sir. Sir, am I audible?
You're audible,
Yeah.
but there's a lot of disturbance behind. If you're using headphones or earphones, take them off.
Okay, sir. Hello, sir.
In the meantime, Dr. Srinivas sir is online. He wants to make few remarks. Now I invite Dr. Srinivas sir to make some opening remarks, sir. Over to Sriram. Okay, so sir will join us little later. Yeah, now it's silent. Dr. Adarsh, yeah, you can start presenting your case, please. Dr. Adarsh?
Good morning, sir.
Yeah, some problem at your end, I believe.
Others, take off the headphones or the earphones. They are the cause
Sir,
of
I have
this.
removed it, sir.
Little
Good morning.
disturbance.
I'm audible now, sir.
You're
Yeah,
audible,
you're
others,
audible.
but there's a lot of disturbance from your end. So you take that off. Take off the headphones, earphones, or whatever you're using.
Now
Yes,
you
sir.
are
I've
clear.
taken it off, sir. I have taken it off.
Now it's better. Please share screen and go ahead. Bhaskar
Yes.
sir, Sriram sir is not in the participant list. In case he comes, just inform either me or Satish. We'll make him the co-host.
Sure, sure.
Good morning, sir. Good morning, everyone. Am I audible?
Yeah, yes, you are audible.
Sir,
Yes,
is my screen visible and am I clear, sir?
Yes, yes. Go ahead, Adarsh.
Okay, sir. So I'm Dr. Adarsh, DNB resident from Yashoda Hospital, Malakpet. I'll be presenting a case on CNS, sir, under the guidance of Dr. Srinivas Midivelli, sir. So there is this 6-year-old female child named XYZ, first by birth order. So born to a non-consanguineous marriage. She's resident of Ketipalli, Nalagunda, belongs to Hindu community. So informant being mother, reliability is good. She presented with the complaints of weakness of left side of the body since 2 days. Coming to history of illness, child was apparently normal 2 days back when the weakness started on the left side of the body, which was acute in onset. So mother noticed it in the morning. When the child woke up from the bed, mother noticed difficulty in getting down from the bed, and there was initial dragging of the left foot was noticed by mother, followed by within 2 hours there was inability to move the lower limbs. The weakness progressed gradually to the left upper limb over a period of 12 hours. Followed that there is paucity of both left lower and upper limb is noted. And along with that there is history of mother also noticed the deviation of mouth to the right side, and there is spillage of liquids while child is attempting drinking. So there is no history of fever, there was no altered sensorium, there was no seizures, there was no vomiting or headache. So there is no history of any cranial involvement cluster, like any abnormal movements of eyeballs, any deviation of eyeball, any drooping of eyelids, and inability to close eyelid, and difficulty in chewing. There was no difficulty in swallowing, except the spillage, except the drooling, there was no difficulty. There is no difficulty in hearing, and there was no nasal regurgitation. There is no history of any involuntary movements. There is no history of any sensory involvement. There is no history of any bowel bladder incontinence. So there is no history of diarrhea, no history of any facial puffiness, no history of decreased urine output, no history of any fever with rash, and there is no history of ear discharge. There is no history of increased paleness or any pain, any bone pains, and there is no history of painful finger digits or fingertips. There is no history of skin rashes or joint pains. There is no history of bluish discoloration or any squatting episodes. There is no history of any bleeding manifestations. There is no history of trauma. There is no history of weight loss. There is no history of recent vaccination. So going to past history, there is no history of similar illness in the past, and there is no history of any previous hospitalizations. Family history, sir, she is born to a non-consanguineous marriage. She first by birth orders. There is no history of similar illness in the family, and there is no history of any tuberculosis contact in the family. There is no significant antenatal, natal, and postnatal history. it was a booked case. There was no history of fever, rash. Regular antenatal checkups were done. Folic acid supplementation was taken. No drug intake or radiation exposure. TT injections were taken. Iron and folic acid supplementation was taken. There was no history of diabetes, hypertension, epilepsy, or thyroid disorders. She was born full term, a normal vaginal delivery, cried immediately after birth with birth weight of 2.8 kg. Started on breastfeeding within 30 minutes of delivery. There was no NICU stay. There was no history of neonatal jaundice. A child is immunized as per national immunization schedule. So BCG scar was present. Developmentally attained all milestones in all the 4 domains appropriate to the age. Presently, child is studying in the first standard. Nutritional history, calories, total calories child is taking is 1650 in the pre-illness period, and protein around 35 grams per day. Expected was 1500 kilocalories per day and protein 30 grams per day as per our age and weight requirement according to ICMR guidelines. So socioeconomic status, they stay in two-room Pakka house with a separate kitchen. So father is a farmer and education till mid school. Mother is housewife. They come under Kupuswamy class 2, sir, upper middle class family. So summarizing my history, a 6-year-old girl child, first by birth order, with no significant antenatal perinatal complications, attained all my. Yes, sir.
Others, go ahead.
Attained all attained milestones as per age in all 4 domains, and immunized as per schedule. Was brought to our hospital with a history of weakness of left side of body since 2 days and deviation of mouth to the right side with no other significant fever history or any trauma history or any other history. So I'd like to think involve CNS involvement and like to examine the CNS central nervous system first, sir.
Okay, Dr. Adarsh.
Yes, sir.
So I think so. In the history of present illness,
yes, sir.
The chief complaint was weakness of left side of the body for 2 days, isn't it?
Yes, sir.
So try to elaborate as much in detail as possible about the one severity of weakness. Okay. Then is there any pattern to weakness? Like is there proximal distal gradient? Is there anything like that? Okay. Then so your purpose of history of present illness is to one localize. Okay, so system, it is more or less clear that it is a nervous system. So there's no doubt about it. Okay,
yes, sir.
But you need to localize where in the neuraxis this pathology may be. So
yes,
with all the information from history of present illness, you should try to answer these 3-4 questions. Where is it? What is it? What is the pathology likely to be? Yeah.
Okay.
And what are the likely differentials? So all these things you should be able to answer by the end of history.
Yes.
So can you go over that part?
Yes, sir. Sir, weakness started when the child woke up from sleep, sir.
Okay.
So initially she was dragging her left foot, sir. Followed by slowly she was not able to move complete of her. She was not able to perform any movements from her left limb, sir. She was not able to lift. She was not able to move her lower limb. And coming to upper limb, initially there was difficulty in holding things, sir. She was not able to hold a glass to given her anything with her hands.
Okay.
So followed by she was not able to lift her hand over the shoulder, sir.
See, don't use the lay terms that's used by parents. So hand is only this part from the wrist and fingers, the palm. This is the hand, isn't it?
Yes, sir.
So then you have forearm and arm. So when you describe it after taking history, you You should describe
Yes.
like whether he was able to reach objects overhead. So that will tell you about the proximal muscles, shoulder.
Yes.
Okay.
Yes, sir.
So gripping is mainly the small muscles of hand.
Yes, sir.
So
Yes, sir.
that's what I was trying to elicit. Is there a pattern of weakness, like which muscles are involved early and which are more severely affected muscles? Is the proximal muscle groups or distal muscle groups? At least by history, you can say, is it gripping small objects is more difficult, like holding
Yes, sir.
spoon, glass, or is
Yes,
it difficult in lifting or reaching for objects overhead? So that will tell you which muscles are more affected, right?
Yes, sir.
So that's what you should ask in the history.
Yes, sir.
So what is it in this case? Are you able to delineate that?
Sir,
Lower limb,
initially,
how severe was the weakness? Because it started in the lower limb first. Is it complete loss of movement, zero power from history?
yes, from the time they noticed, by 2 to 3 hours, it was complete loss of the movement, sir. She was not able to move her lower legs.
Okay. Was the child able to walk when the child woke up from sleep?
Yes, sir. She was. They were finding that she was. It was difficult to get down from the bed. Then she was dragging her left foot, sir.
So at least there was some power, right? At the
Yes,
beginning.
Yes,
Okay.
sir.
So dragging can be due to proximal weakness, or it can be distal weakness also. Okay.
Yes.
I think you should try to get that information. Probably you were not focusing on that part when you took history.
Yes, sir.
Okay, that is important. So it involved the lower limb first, followed by upper limb.
Upper limb, sir.
And then deviation of angle of mouth to right side.
Yes, sir.
Okay. So the next question is, where is the pathology? In the nervous system, in the neuraxis, where is the pathology?
Sir,
So
it
that's
could
what you
be.
should try to answer.
Yes, sir. It could be upper motor neuron.
Okay. Where in the upper motor neuron? So where does it start from? From cerebral cortex to
Cerebral cortex. Yes,
above
sir.
the anterior horn cells in the spinal cord. All that is upper motor neuron.
Yes, sir.
So what all questions will you ask to delineate this? Like which part of upper motor neuron?
Sir,
is
I'll ask
applied?
about the any involvement of cortex, sir, by asking about the
Okay.
sense, about the sensorium,
Okay.
any seizures,
Okay.
any raised ICT pictures, sir, vomiting, headache.
Okay.
So if there is involvement of any of these things, then I think mostly the lesion is in cortex, sir.
Cerebral cortex. Okay.
Cerebral cortex. The pattern of, then I'll ask for the involvement of cranial nerve, sir.
Okay. No, so we are jumping from cortex to cranial nerves.
Then
Is there anything in between?
Subcortical region and internal capsule, sir.
Okay. So what questions will you ask for subcortical involvement? Like subcortical is white matter basically.
Yes, sir.
And basal ganglia.
Yes, sir. Subcortical, I'll ask about. So subcortical will be same as cortex, sir. It will be contralateral hemiplegia. But there won't be any seizures or any altered sensorium will not be there, sir.
Right.
And,
so usually there is no altered sensorium. Seizures are less likely. Okay. It is not absolute, but less likely. Okay.
Yes, sir. Yes, sir.
Okay.
But in the subcortical regions, sometimes sensory loss is expected, sir.
Where like which involvement subcortical will cause sensory loss? It's a simple anatomy. Where does the sensory relay happens? Thalamus, no?
Yes, sir. Thalamus.
Only if there is a thalamic involvement, you can have sensory loss or any sensory symptoms, positive sensory symptoms.
Yes, sir.
Okay. How about basal ganglia involvement? Can that also cause acute onset weakness?
Basal.
It can cause,
yes,
right?
It can. Yes,
so
sir.
what questions will you ask in the history?
We'll ask about the involuntary movements, sir, if the basal ganglion is involved.
Okay. Involuntary movements in the form of?
Sir, chorea, athetosis,
Okay.
dystonia.
Right. So you should ask questions like of any involuntary movements, any like any involuntary dancing type of movements, twisting movements of the limbs, right?
Yes. Yes,
Or
sir.
any sudden flinging, violent flinging movement. These are all extrapyramidal movements.
Yes, sir.
Then you go to brainstem.
Yes, sir.
Okay. So what questions will you ask? So there is a cranial nerve involvement from the history, isn't it?
Yes, sir.
Like there is deviation of mouth to one side.
Yes, sir.
So you have to localize it, whether it's the upper motor neuron facial weakness or lower motor neuron.
Yes, sir.
Okay, so how do you do that from history?
Sir, if it is lower motor neuron, then there will be complete involvement of one side of the facial nerves.
No, history,
muscles,
what
sir.
will you ask? We are talking about history here. So what
Yes, sir.
questions will you ask the parent to understand whether it is upper motor or lower motor neuron facial weakness?
Unable to close the eyelid, sir.
Inability to completely close the eyelid. Okay.
Completely. Yes, sir.
And what else?
Loss of wrinkles while.
Okay, when he's looking up, there is a reduced wrinkles on the same side.
Yes, sir.
Okay. What else? Even reduced blinking also. Many times when the, of course, parents may or may not have observed, but reduced blinking because of the weakness of orbicularis oculi. So these things will tell you whether it is a complete facial weakness versus only lower part of the face is affected.
Yes, sir.
Yeah. And what else? Any other associated nearby structures involvement? Suppose there is also squint, sudden onset squint with eye deviation to medially. What does that indicate?
Sir, lateral rectus palsy.
So what does that tell you?
Sir, that pons has been involved, sir.
So the nearby cranial nerves are affected. So sixth nerve is also likely affected, and seventh nerve.
Yes,
so you will think of a brainstem involvement.
Yes, sir.
So, and also, if there is brainstem is affected, what other symptoms will you see? You will also see altered sensorium. See, all the ascending reticular activating system passes through the brainstem, right?
Yes,
So almost always there is an altered sensorium. So if you
Yes,
have
sir.
more than one cranial nerve palsy, which is explained by the anatomical location, encephalopathy, you will definitely think of a brainstem involvement.
Yes, sir.
Okay. So all these questions you should have asked to say that, okay, there are no abnormal movements, no twisting movements of the limbs on that side, no sensory symptoms. Okay, no loss of sensation on that side. There is no history of squint or eye deviation to one side. So once you say all these things, then the examiner will understand that, okay, you have asked these questions to localize where is the likely pathology.
Yes, sir.
Okay, so that is the first step.
Yes, sir.
So based on what you said, it looks like there is no history suggestive of subcortical structures involvement, basal ganglia involvement, or the brainstem involvement. So subcortical, it's difficult to say. Cortical involvement is less likely because there are no seizures, no altered sensorium. So probably it is a subcortical structures involvement.
Yes, sir.
Okay. Now, next question is, what is it? What is the pathology?
Yes, sir.
So what is the likely pathology? So depending on the how symptoms evolved, right? So initially there is a lower limb weakness. Then after about 10 to 12 hours, there is weakness of the upper limb. And then
deviation of.
Deviation of, So what does that tell you?
Sir, it is gradual in onset, sir. The weakness that is occurring is.
Okay. See, it is evolving over hours. So not everything has happened at one go,
Yes, sir.
right?
Yes, sir.
So it has evolved over at least 12 hours.
12 hours. Yes, sir.
So what pathologies comes to your mind when some disease is evolving over few hours?
Any vascular events or any thrombotic events?
Thrombotic or embolic? Which is more likely with that kind of
Embolic
evolution?
is more likely if it is acute, sir.
Embolic.
Yes, sir.
Why?
If it is
Which
yes,
is
sir.
more sudden, embolic or thrombotic?
Embolic is more sudden, sir.
So thrombotic is more gradual, right?
Gradual.
Sometimes it happens over hours to days also.
Yes,
So
sir.
it is more likely to be a thrombotic if it is a vascular pathology.
Yes, sir.
So one is vascular, like ischemic or hemorrhagic.
Yes, sir.
What else? Any other pathologies you can think of?
Sir, any demyelinating disorders?
Okay, demyelinating disorders. Okay, correct. So they can also evolve over hours and sometimes days also, rarely. Okay.
Yes, sir.
What else?
Sir, any space occupying lesion, but
Okay, space occupying lesion. Okay, in the subcortical structures, right?
yes, sir.
Because there is no raised intracranial pressure features, there is no headache, no altered sensorium, so it is less likely to be involving the cortex.
Yes, sir.
Okay, so less likely from the history.
Yes, sir.
Okay, so now third question is why? Why means like other, suppose if you are thinking of a ischemic stroke involving subcortical structures, then what are the other clinical clues? Like, is there trauma before this happened, previous day? Is there any oral trauma with child holding something in the hand?
Yes, sir.
That can also cause thrombus. Any neck trauma?
Neck.
Right?
Yes, sir. Yes, sir.
Any history of transfusions in the past? What does
Yes.
that tell you? Past history of transfusions?
Any hemolytic anemias?
Yeah, any hemolytic anemias, more specifically?
Sickle cell anemia.
Yeah, sickle cell. Okay.
Yes.
So all these questions you should ask to answer these 3-4 questions before you complete your history.
Yes, sir.
Okay, right. So can you quickly summarize now? And Sriram Reddy sir, any other questions, sir?
Unmute చేయండి sir. Unmute చేయండి. Sriram Reddy garu. Unmute. Satish? Satish.
Yes, sir.
Sir, the unmute చేయి. Sriram sir.
Yes, sir. Sir can unmute, sir. నేనైతే చేసి పెట్టాను సార్. సార్ నుంచే మ్యూట్ చేసి పెట్టారు సార్.
Sir, unmute చేయండి sir. Unmute click చేయండి. Actually, sir is in alumni meeting.
Hello.
Yes, sir. Audible. Vinipistunnadu.
It's very excellently presented. Are you please hearing me?
Yes, sir.
Excellently presented, but the only way, the negative points, what you are elaborated, it should be in order of importance to be given to this case. You went in general, like for example, you have started with the no history of diarrhea, no history of weakness. So here, as you know, the case is acute, short duration. So what are the causes common presented with such a, it is clear that is a vascular origin. So history of trauma to be given first in order of, because a child is known to have, then a history of a picture of any encephalitis like, or picture of any giving transfusions which may cause any embolism or thrombosis, any bleeding disorders which may cause any. So like that you would have gone. It's excellently presented, no doubt in it, but order of negative points also to be taken care. That
Yes, sir.
importance to be given to the most possible negative points. That is the only thing. Otherwise, the way you are presented is excellent. And other than that, as Sir said, the history of localizing the lesion is more important. You have to try to put it in the present illness itself. Because it is very clear. So what are the causes from starting from cortex to brainstem or even spinal cord? So which causes the hemiplegia? So starting from seizures to be taken first. There are no history of seizures to be given importance rather than talking about no history of diarrhea or puffiness. So seizures, history of trauma, these things to exclude the different areas where it is no history of facial deviation. That would rule out the places of cranial nerves. So like that, please do like that. Otherwise, it's excellent presentation. Thank
Yes,
you.
sir. Yes, sir.
So always once you know the chief complaint, like history of weakness on one side, so all these
Yes.
questions should go in your mind. Where is
Yes,
the
sir.
pathology? What is the likely pathology? And what are the differential diagnoses? So as Sir said, there is nothing like positive history or negative history. All relevant history should come at once. Suppose if you
Yes.
are thinking of localizing, so you should ask the questions next to each other. Like you say, no seizures, no altered sensorium, no twisting movements, right? No involvement of misalignment of eyes, no squinting noted. So when I see that series of questions, I know you are looking to localize the lesion, right?
Yes, sir.
The next series of questions you will ask, what is the pathology? So vascular pathology is demyelination. So you are asking relevant questions at one go. So
Yes,
that's
sir.
how the thought process should be. So don't put it like just a checklist of negative history. It has to be relevant to your chief complaint and what is your thought process.
Yes, sir.
Okay.
Yes, yes, sir.
So suddenly, if I'm hearing painful fingertips, I can't grasp what are you like asking this question about. Okay, so all relevant questions should come at one go, and it should have relevance and flow with what you are saying.
Yes, sir.
Yeah.
Sir, I would like to add, others, can you elaborate why did you ask this negative history? So that I think the ongoing DNB PGs will learn. Because you asked so many negative history. So why did you ask, as Sir said, how to ethological classification? Why did you ask so many negative history? Can you tell in detail?
Yes, sir. Sir, I asked diarrhea about any dehydration leading to cortical venous sinus thrombosis, sir.
Okay.
Any facial puffiness and decreased urine output in nephrotic syndrome, it could be like prothrombotic events can happen, complications of nephrotic syndrome leading to strokes.
Yes.
Sir, fever with rash, any varicella or any autoimmune conditions, connective tissue disorders.
Okay.
So
So, yeah.
what is the duration of what is the time line you are asking fever with rash? If you are thinking of varicella, like in the past 1 month, 2 months, 3 months, 1 year.
It should be 2 months to 1 year.
Yeah. So post varicella angiopathy can present up to 1 year also.
Yeah.
So you
Yes,
should
sir.
ask any history of chickenpox in the last 1 year if you are thinking of a ischemic stroke.
Yes, sir.
Well,
So when you ask paleness and other things,
Yes,
you
sir.
should also ask about any blood transfusions in the past.
Yes, sir.
Yeah. So as I said, all those are relevant and they should come together.
Yes, sir.
And why did you ask about that painful, as Sir asked, painful fingertips?
Sir, to rule out sickle cell disease and infective
Okay.
endocarditis also.
Right.
Yes.
Good. Shall we go for the examination part?
No. The other important thing is how you synthesize your history. That's also important thing postgraduate should learn. So others, can you just summarize? So remember,
Yes,
summary should not be repetition of what you said in the history.
yes,
So
sir.
it is how you synthesize what all information you got from history.
Yes, sir. So this 6-year-old child want a non-consanguineous marriage first by birth order with normal developmental history, presented with acute onset of left-sided hemiplegia, sir, with
Okay.
uh, with facial nerve involvement.
Mm-hmm.
Sir, it could be probably due to any uh, vascular origin etiologies.
Okay. See, that's what I was trying to tell you. When you synthesize, so put everything that we have discussed now till now. So you say 6-year-old previously healthy girl. Okay.
Yes, sir.
Once you say previously healthy, you assume that there is no medical problems earlier, with acute onset of left upper and lower limb weakness, probably upper motor neuron, probably, right? So that's where
Yes,
you localize to. Then left facial palsy, probably upper motor neuron, right? So now
yes, sir.
this is all the exercise that we did for. So you want to localize. So left
Yes, sir.
upper motor neuron type of hemiplegia with left UMN facial palsy of acute onset, and
Yes, sir.
possible pathologies. Because of evolution over 12 hours, there is a ascending type of involvement, upper lower limb involvement followed by upper limb involvement.
Yes.
These are my pathological differentials. So pathologically, you say first possibility is a vascular pathology.
Yes, sir.
Okay, because of the way it evolved. And second is any demyelination
Yes, sir.
or any other space arc lesions is less likely.
Yes.
Then you can say any inflammatory, infective, whatever, depending on what history you have got. Then go
Yes.
to the individual differential diagnosis.
Yes,
Okay.
sir.
So,
Yes.
so basically, when we ask to summarize and interpret, this is what we mean. So
Yes, sir.
in summary, you have to give medical terms to what you have got from history. So they will say difficulty in moving upper limb. That is the history from parent. But when you synthesize and summarize, you say left acute onset, UMN weakness. This is what
Yes.
you have synthesized now, right?
Yes, sir.
Then
Yes, sir.
left UMN facial palsy.
Yes,
Okay.
sir.
Possibly the localization is subcortical structures, subcortical white matter.
Yes,
Okay.
sir.
So this is localization, then pathology, then individual differential diagnosis.
Yes, sir.
Okay.
Yes, sir.
Then when the examiner asks you about what are the differential diagnoses, you should give in the order of most likely possibilities to least likely. And without asking, you should tell why it is more likely. Because of these things, I think this acute ischemic stroke is a possibility, possibly of thrombotic pathology, thrombotic nature, because it evolved over 12 hours. However, the odd points are these things.
Okay, sir.
My second differential is a acute demyelinating disorder because of these points, but odd points are so and so. There is no preceding febrile illness, no recent vaccination. So you should tell odd points as well as points favoring your differential diagnosis.
Yes, sir.
Okay. Sriram Reddy, sir.
Unmute చేయండి సార్ శ్రీరామ్ గారు unmute.
Hello.
Yes.
Hello.
Yes.
Sir, just I want to ask you a small question. What are you're telling about varicella, post-varicella? What is the presentation of post-varicella in neurological place? Which place of brain gets involved in varicella, post-varicella?
Sir, it is a angiopathy, sir. Angiopathy involving mainly the vessels in circle of Willis. Typically anterior circulation, middle cerebral and anterior cerebral circulation, rarely posterior cerebral artery also. So it's basically angiopathy.
Angiopathy, but mostly gets involved in the cerebellum. That is what we call cerebellar ataxia is the common presentation what we are observing in the past after
Yes,
3 to 4 weeks of this thing.
Correct, sir. Post varicella cerebellitis. Cerebellitis. Yes, sir. But here, I think in his presentation he meant later complications, sir, like late complications in presenting with.
That's
Yes. Thank you, sir.
Okay. Go ahead. Go ahead.
Yes, thank you.
Please go ahead.
Yes, sir. So should I go to the examination part, sir?
Yeah, you can go to examination.
Yes. Examination: a 6-year-old female child, conscious, oriented to time, place, and person, well nourished, lying in the bed with the left upper arm abducted and flexed, with the lower arm extended and adducted.
Okay.
So,
Go back, Adarsh.
Yes, sir.
So can you imagine how is the left upper arm abducted and flexed? If he's lying supine, so how will be the position of left arm? Abducted and flexed. Can you imagine? It will be in the air.
Adducted and flexed.
No, even what is the flexion of arm? So that's why I said, see, upper limb for you should be differentiated. Arm, forearm, and hand.
Yes, sir.
Okay. So even if it is adducted and flexed also, it will be in the air.
Yes, sir.
So don't use vague words when you are examining. Use medical terms. Okay.
Sir.
How is arm position?
Okay.
Yeah. So lower limb extended and adducted, how will it be? What is lower limb? Lower limb being is whole of from hip to toes. Okay.
Yes,
So use medical terms. Is it extended at hip, extended at knee, extended at ankle? So these movements happen at joints, isn't it?
Yes, sir.
So don't use vague words.
Yes, sir. So vitals, temperature is 98.6 degree Fahrenheit measured in the right axilla. Heart rate is 102 beats per minute. Pulse is regular, good volume, normal in character, no radio-radial delay, no radio-femoral delay. All peripheral pulses are well felt. Respiratory rate is 22 cycles per minute. Blood
So
pressure is
anything in the pulses that you want to say it here? Anything else in the pulse examination? Is just talking of peripheral pulses is fine, or you want to comment on central pulses also? So you are thinking of a thrombotic stroke, isn't it?
Yes, sir.
Ischemic stroke with thrombotic nature. So don't you want to look at the carotid pulse?
Yes, sir.
So that's what, see, examination, when you start your examination, have few points in mind that you don't want to miss based on what your differential diagnosis were.
Yes, sir.
You are thinking of ischemic stroke, which evolved over 12 hours. We know most likely it is a thrombotic in nature. So
Yes,
carotid dissection can cause thrombotic stroke.
Yes, sir.
So you have to tell about carotid pulses, whether they are symmetric, asymmetric, well felt both sides.
Yes, sir.
So it has to be relevant, remember. Whatever examination you say, all those things should point to what you are looking at.
Yes, sir.
Okay, go on.
Blood pressure is 96/54 mmHg measured in supine position on the right upper limb with appropriate curve. It is coming to 50th centile for our height percentile. Saturation levels are 98% in all 4 limbs.
Do you want to measure forelimb blood pressure? Is that relevant? Yes. Forelimb BP? Is it important?
Yes, sir.
How? Suppose right side blood pressure is more than left side. Does that mean anything? Or upper limb blood pressure is more than lower limb blood pressure. Does that mean something? So that's why don't say these things as a routine or checklist. Okay, BP, saturation, pallor, cyanosis. So, you already thought of some differentials. Think what all things you can find on general examination, right?
Yes. Yes.
So, any differential blood pressure, either between the limbs or between upper and lower limbs, you should think of a large vessel involvement. So it may be coarctation of aorta, it may be Takayasu disease. You can have differential blood pressure and differential pulse.
Yes, sir.
See, for all cases of stroke, neurological examination is the least important. Remember this. Most important is general examination and other system examination as to get the clues. Right?
Yes.
So weakness
Yes,
is
sir.
very obvious. So parents have already told you there is left upper limb weakness. And from
Yes.
history, you have already seen that it is likely UMN weakness. So there is nothing additionally that you are going to get by neurological examination. Very, very little.
Yes,
Most
sir.
of your clues will come from general examination carefully and a proper relevant, looking at proper relevant findings.
Yes, sir.
So that's why all these are very, very important.
Yes, sir.
Go on.
So anthropometry, she is 18 kgs. Length is 112 centimeters.
Okay.
BMI is 14.4. It is between 25th to 58th centile according to IAP growth chart, sir. 5 to 18 years growth chart. Sir, head to toe examination is normal. I've looked for eyes, oral cavity for any lesions, any trauma, ears for any ear discharge. There is no pallor, icterus, clubbing, cyanosis, edema. There is no lymphadenopathy.
How are neurocutaneous markers relevant here?
Sir, like in Strudge-Weber syndrome, it is associated with
Okay. Stroke-like episodes.
stroke-like episodes, sir. Yes,
Okay.
sir.
What other neurocutaneous markers may be important here?
So neurofibromatosis, if Kephela spots are present, it is
Okay.
Moya is associated with neurofibromatosis.
Very good. So you should look for Kephale macules. There are multiple in number. You will think of Moya associated with NF1. Okay. Sturge-Weber syndrome. Anything else? If there are multiple cutaneous hemangiomas, that may also be relevant. There may be associated hemangiomas in the brain also.
Okay, sir.
Okay. Anything else in the general physical examination?
Look for the markers of rheumatic fever or infective endocarditis.
Yes. Okay. So think of all causes of stroke, if that is your first differential, and see what all cutaneous and other general physical examination findings you can get. Right? So all those things should be specifically told when you are presenting your case.
Yes, sir.
So rather than saying no neurocutaneous markers, so I would be more happy if you had told there are no Kephale macules. Then I know you are looking at NF1. There is no facial hemangioma. There are no cutaneous hemangiomas. There is no varicella rash. Okay.
Yes.
So this is what will make you a better presenter when you present in exam than presenting like a checklist.
Yes, sir.
Okay. Go on.
Sir, nervous system examination, higher mental functions. Child is conscious, oriented to time, place, and person. So memory is intact. Speech and language was normal. Coming to cranial nerve examination, the olfactory nerve was normal on the both sides. Optic nerve, gross vision was normal. Visual acuity was 6/6. So visual field was normal. Color vision was normal. Fundus was normal. Third and fourth, sixth examined together. Extraocular muscles are there is no weakness of extraocular muscles. Direct and indirect light reflex was normal.
How do you, Adarsh, how did you say visual acuity 6/6? How did you check?
So with the Snellen's chart.
You are carrying a Snellen chart? Okay, so don't get into that. You are not expected to use knowledge chart as exam at PG level.
Yes,
You
sir.
should say what do you do on bedside, right?
Yes, sir.
Finger
Yes, sir.
counting, reading alphabets from a distance, right?
Yes, sir.
Finger waving. Those are the things you are expected to do. Bedside
Yes, sir.
visual acuity testing. Okay.
Yes, sir.
So that's what I'm saying. So you have written many things as a routine. Okay.
Yes, sir.
So I can ask you, how did you check olfactory now?
Yes.
How did you check olfactory now?
Sir, we'll ask the child to close eyes and one nostril. We'll use the familiar things like chocolate, something which is familiar to the child, and ask her
Okay.
to smell. Then ask her to identify.
Okay. What is the first question you ask when you check for smell? Will you ask what smell is this? So that's why, so don't go into things that you have not done, and only those relevant things you can mention. Okay.
Okay, sir. Okay, sir.
Okay, go on.
Sir, facial nerve. Child was able to close both eyelids tightly. There was wrinkles present on the forehead when child is looking up. There is deviation of angle of mouth noticed on smiling to the right side, looking like a left UMN facial palsy, sir.
Okay. And good that you did anterior two-third of tongue sensory examination. What did you check, by the way, in anterior two-third?
Sir, for the taste, we have to check, sir.
Okay, fine. Okay.
So there was rest of the cranial nerve examinations are normal, sir.
Okay, fine.
So coming to motor system, bulk was normal on examination, sir. It was same on both sides. Tone, there was decreased tone in the left upper limb and lower limbs. Power was checked in individual at individual joint level, sir. At shoulder flexion, power was 0 in shoulder joint and elbow joint, wrist, hip, and knee, ankle on the left side, sir.
Okay. So your job made easier. So 0 power completely. Okay.
Yes,
See, another thing is you don't say power at hip joint. Power is not for joints.
muscle.
Power is for muscle groups. Okay.
Yes.
Say hip flexors. When I say hip flexors, it's a muscle group of muscles. Hip abductors, hip adductors. So muscle power is for muscles, not for joints.
Yes, sir.
Only joints, you only talk of range of movement of a joint.
Yes, sir.
Okay.
Sir, superficial reflexes, plantar reflex was normal at right side and it is extensor on the left side, sir. Abdominal reflexes were absent. So deep tendon reflexes, it was normal on the right side. It is normal to exaggerated on the left side, sir.
Okay, tell me, what do you mean by exaggerated knee jerk in this patient? Can you describe it? What is exaggerated knee jerk in the left side in this patient?
So exaggerated, we call knee jerk in a children if it is more than 6.
No, I'm not talking about clonus. So you said power is 0 at all muscle groups in the lower limb. So
Yes,
is
sir.
there a moment to even say that it is exaggerated knee jerk? How is that possible? With 0 power, you don't see any movement at all, not even a flickering of movement, muscle. So how did you get exaggerated knee jerk? Isn't it contradictory?
Yes, sir.
So did you get a movement when you checked deep tendon reflexes?
In the knee jerk, there was normal response, sir.
So there was anti-gravity movement. Normal means when you strike with your knee hammer on
Yes,
the
sir.
tendon, quadriceps tendon, you get a extension of the knee. That is knee jerk.
Yes, sir.
Okay. So normal means there should be anti-gravity movement of knee extension.
Yes, sir.
Was it there?
Yes, sir.
So what is the muscle power if there is anti-gravity movement of knee extensors?
Three.
At least 3/5.
Yes, sir.
So why did you say 0 power?
I think others, sir, there was a different time of examination. That's the reason he might be mentioned that, sir, because when the child came on day 2, they examined and they took the history for the exam. So that might be the reason, sir. They examined again the CNS on the day 6 or day 7 where the child got improved. So that might be the reason for mentioning it as exaggerated.
Yeah, remember that for all postgraduates, I think if the reason for this confusion is there is no voluntary movement at all muscle groups, that's why you said 0 power. See, any
Yes, sir.
movement elicited with whatever maneuver, either it is done by the patient himself spontaneously, or you induce it by, say, scratching or tickling. That's what you do in infants, isn't it? Infants,
Yes,
they
sir.
don't do voluntary movements. So you tickle and see whether there is anti-gravity movement or not. So here you are eliciting this by reflex maneuver.
Yes,
So
sir.
if there is a movement with whatever maneuver you did, you have to give the highest possible movement and say the grade of power like that.
Yes, sir.
So on reflex, like the hammer tapping, if you are getting anti-gravity movement, that is the best power. You should say that 3/5
Yes.
or 3 minus 5, depending on what you got.
Yes,
Okay,
sir.
don't say 0 power.
Okay, sir.
So this is the, again, this confirms that this is a upper motor neuron type of weakness. Because if
Yes,
it is
sir.
LMN, whatever maneuver you do, you scratch, tickle, tap, you don't get that movement.
Okay, sir.
Okay.
Okay, sir.
In newborns and infants, this is a very important point to differentiate. If you have a hypotonic baby or infant, if the spontaneous movements are absent, but on reflexes, suppose Moros or other reflex maneuvers, if you are getting anti-gravity movements, it is more likely to be upper motor neuron type of hypotonia or central hypotonia versus peripheral hypotonia, where you will not get any movement with whatever maneuver you do.
Okay,
So
sir.
infants, it becomes very important, this point, how will you differentiate central hypotonia versus neuromuscular hypotonia?
Yes, sir.
Okay.
Sir, we are not able to assess gait at that time, sir.
Yeah, if he's not able to stand, obviously you can't comment on the gait. Okay.
Sir, sensory system examination was normal, sir. There were no signs of cerebellar involvement. There are no involuntary movements. There are no signs of meningeal irritation, and there are no signs of rise intracranial tension. Spine was normal.
So again, in cerebellar, when you say cerebellar signs, if the muscle power is very low, you can't comment on the cerebellar signs.
Yes, sir.
Suppose child is not able to lift his finger only, you can't talk about abnormal
Yes.
or incoordination with the finger nose test.
Yes,
Correct?
sir. Yes, sir.
Okay.
Other system examination, cardiovascular system was normal. There was no, the precardium was normal, sir. Apex beat was localized to fifth intercostal space. There was no heart sounds were normal. S1, S2 were normal. No added murmurs. Respiratory system, chest movements was bilaterally normal and symmetrical. Bilateral air entry was equal. No added sounds. Abdomen was soft, non-tender. There was no organomegaly. Diagnosis.
Yeah. Again, I think you have to summarize with both history and examination together.
Yes, sir.
Okay. Then give your differential diagnosis, interpretation and differential diagnosis.
Yes, sir. Sir, a 6-year-old female child with left-sided weakness and have come with the complaints of left-sided weakness of acute onset with no developmental delay or no perinatal antenatal significant history. On examination, there was hypotonia, decreased power on the left side with exaggerated reflexes and plantar reflex being extensor, probably acute.
Others, again, you are repeating examination findings. See, that's what synthesizing means. So after your history and examination, you should have written a brief summary of 4 or 5 lines. Say again, same thing, 6-year-old previously healthy child with acute onset left upper motor neuron type of weakness. So once you say upper motor neuron, it is understood. Brisk reflexes, all those things are understood. Okay.
Yes.
Left UMN weakness and left UMN facial palsy. So it is understood.
Yes.
Okay. So that's all. If there is any other additional point, you can mention. So left dystonia, left coriform movements. If it is there, you add it.
Yes, sir.
Okay.
Yes,
Don't
sir.
repeat from history and examination again.
Yes, sir.
Then give your interpretation of your case and then differential diagnosis.
Yes, sir. So localization of lesion could be the subcortical region, either it is coronary radiator, internal capsule involving the middle cerebral artery, probably of vascular etiologies.
Okay, fine. I think for examination, we have not found any new clues, isn't it?
Yes, sir.
So all the things like likely cerebrovascular, like vascular pathology, subcortical localization. So all those things we already inferred from the history.
History, yes, sir.
So there's nothing really coming from examination. You just confirm that it is upper motor neuron weakness.
Yes, sir.
Yeah. Okay. So, but ideally you should present that in a systematic manner. Summarize in medical terms. Now, when you say summarize both history and examination together, give a name to your finding. Okay, don't say weakness of left side. Say left upper motor neuron weakness or left UMN type of hemiplegia. So give a name to your finding now. Okay.
Yes, sir.
Okay. Go on.
Sir, differential diagnosis.
Yeah. So what is your first differential diagnosis?
Sir, any vasculopathies?
Okay, so again, for all postgraduates, important is you don't have to give one differential diagnosis, rather think of group of disorders. Okay, so first in this child, the first group of pathologies that you would think is arterial ischemic stroke, right? So arterial ischemic stroke can be due to hundreds of reasons. Vasculopathy is one of them. So you don't have to specifically talk of vasculopathy unless there is a strong reason from history or examination. Say arterial ischemic stroke, that is one group.
Yes, sir.
Okay. So that can be thrombotic, embolic due to cardiogenic emboli or a carotid dissection, or it can be angiopathy due to post-varicella, post-infective vascular. There are multiple causes. But I think of group of disorders when you present your case.
Yes, sir.
Okay.
first differential diagnosis will be arterial ischemic stroke, sir.
Yeah.
Then it could be any acute demyelinating disorders.
Hmm.
Then
So
any
you
space
should
of
also say what are the points in favor of a demyelinating disorder and what are the odd points. Because that's the logical next question you are going to get from examiner.
yes, sir. Sir, any UMN weakness, that is hemiplegia, they can present in demyelinating disorders, sir. But there is no any preceding febrile illness or any vaccination which triggers this, and there is no any encephalopathy picture, sir, which is present in demyelinating.
Okay. So do all demyelinating disorders present with encephalopathy?
No, sir.
Yeah. So it is only 2 days duration. So it's very acute. Okay.
Yes, sir.
So usually if you are thinking of ADEM, yes, encephalopathy is a prerequisite to diagnose
Yes.
ADEM. But there can
Yes.
be other demyelinating disorders like
Uh,
which may not have encephalopathy. What are they?
multiple sclerosis.
Okay, multiple sclerosis, very rare in pediatric age group, especially 6-year-old. What are the other commoner demyelinating disorders which may not have encephalopathy? So think of those group of disorders: neuromyelitis optica, right? Neuromyelitis optica, spectrum of disorders. So NMO, MOG antibody associated disorders, they can present with only white matter involvement, so may not have encephalopathy.
Yes.
Okay, they may not have any febrile illness preceding.
Yes, sir.
So the typical history for demyelinating disorder you are expecting is mainly for ADEM. Okay.
Yes, sir.
But other demyelinating diseases like NMO spectrum, they can present with similar symptoms.
Yes, sir.
So in the same, when you thought of these differentials from history, you should have asked about any vision complaints also, because you are thinking of NMO as one of your differential diagnosis. Any
Okay, sir.
reduced vision in one eye or both eyes. Any symptoms referable to spinal cord involvement. There may be brain involvement, but you can have multifocal involvement involving optic nerve and cranial nerve, spinal cord also.
Okay, sir.
In many of these demyelinating conditions. So you should ask all that history. Suppose this child had all this history and there is some urinary complaint like urgency, frequency of urination, or involuntary micturition, you would definitely think of a demyelinating disorder.
Yes, sir.
Right?
Yes,
There is a spinal cord involvement also possible.
Yes, sir.
Okay. So space occupying lesions and posterior reversible encephalopathy, all those are very unlikely or very less likely. They should be down in the list.
Yes,
Okay.
sir.
And again, press is, this is not a common presentation of press. Usually it is a bilateral phenomena, right? They usually present with the seizures and encephalopathy. Hemiparesis is extremely uncommon with press.
Okay, sir.
Your blood pressures, we have already seen that they are normal.
Normal.
Right.
Yes,
And
sir.
there is no other systemic disease you can think of as cause for press, like any uremic conditions or vasculitic features. So I think this may be inappropriate having press in the differential diagnosis here.
Yes, sir.
Okay. So probably arterial ischemic stroke would be first possibility with due to 1, 2, 3, 4 you can think of any underlying cardiac structural abnormality, congenital heart disease, or a vasculopathy, carotid dissection.
Yes, sir.
Then demyelinating disorders, mainly NMO spectrum. Okay. Then space occupying lesions. So, and stroke-like episode, those are very, very uncommon. So keep rare conditions in the down in the list.
Okay, sir.
Sriram Reddy sir and Dr. Srinivas, anything you want to add?
No, it's excellent presentation, sir. Hello?
Yes, sir.
Hello?
Yes, sir, we can hear you.
No, it's excellent. It's excellent presentation, sir. You have gone into so much of depth. Really, it has that case itself looks to be typical, and the presentation what you have made was excellent actually. What we usually ask are simple questions like just differentiate between upper motor neuron and lower motor neuron. Difference between upper motor neuron facial lesion and lower motor facial lesion. Just what are the signs of increased intracranial tension, and how do you trace the cranial nerves? For example, he said tested the olfactory nerve. So what are the, where is the center of olfactory nerve, and how do you trace it, and how you examine? So, but the way the case as traced and discussed, excellent, sir. There is no chance to ask or interfere. Just I am hearing so nicely. It was excellent, Dr. Ramesh. Thank you.
Thank you, sir.
Dr. Subramanian, sir. Dr. Subramanian, sir, would you like to make?
Small. Dr. Ramesh, I think he has mentioned about reduction in the tone left side.
Yeah. Yes, sir.
Did he explain the reason behind of any hypotonia that was there? Hypotonia, if it were to be so, what could be the cause? So, because we are presuming it to be human lesion, how he would explain hypotonia is, I think,
yes,
maybe a question.
Yes, sir. He didn't explain. Others, you want to explain why there is hypotonia and you are talking of upper motor neuron type weakness?
Sir, in the initial phase of human lesion, there could be hypotonia.
Yeah. So in the acute, hyperacute and acute phase, the tone may be low or sometimes normal. Okay. As the time passes, you may get more definite UMN signs like spasticity or rigidity depending on the location.
Yes.
What was the duration, sir? I'm sorry.
2 days.
Total
2 days.
2 days, sir.
Okay.
2 days. 2 days.
Okay.
Excuse me, sir.
Sadhana,
Excuse me, Dr. Ramesh. This student was telling repeatedly there is no vaccination. Just I am asking one question. What are the vaccines which cause the neurological effect? Do you know? I am asking as a student.
Others,
Measles and rubella vaccine can.
which, sorry,
No, again, you should tell in order of frequency and incidence.
association.
Association.
Vaccine.
Is the measles vaccine cause so much of any neurological? Do you know what is the incidence of measles vaccine causing the neurological signs? No, it is 1 in 10,000, 1 in 10 lakhs, or 1 in even 10 million. It's not common. What are the common vaccines which can cause neurological signs?
So pertussis can cause.
No, again you are telling.
Influenza.
No, influenza and rabies. These are the vaccines which can cause.
Okay, sir.
Okay. Thank
I think rabies sometime back, neuroparalytic reactions following the simple vaccine was there, but now
That's what.
vaccine is not there. It is already removed from the list. I think
That's what.
rabies,
But
all modern rabies vaccines are extremely safe. Regarding the hypotonia, I would like to add something more. What was I say? How will you differentiate if there is a hypotonia with the UMN and LMN clinically in acute phase? As you said, there is a stage of neuronal shock which lasts for a couple of weeks, which may last for about a couple of weeks. That were to be the case, how we will differentiate a human from LMN clinically during acute episode?
Sir, superficial reflexes, plantar reflex will be extensor, sir.
Good. So that is what I wanted to know. So the plantar you have to search for, and if it were to be extended, that is possible. Of course, it can be better interpreted in an older stage, but not in a smaller patient. But
yes,
that is good. So therefore, we have to keep in mind, just because patient has got some hypotonia or floppy limb, you cannot take it for granted. It is always LMN. It could be human as well. Much depends upon the carefully taken history, whether the lesion is there at what level. So history is most important to find out where it could have been, and history examination gives you the, at that time, but the history gives the clue regarding the etiology also. Right. Thank you.
yes.
other than that, the boy was excellent, good, but the examination always a student should learn to examine from head to toe, from above down, because what he was telling is, he was telling about the palpation of the vessels. He was telling you from the down to above. He did not talk about the carotids and talking about the palpation of the inguinal vessels and other vessels. Even reflexes, superficial reflexes, you should start from above down, from corneal reflex to abdominal reflex, and then go to the plantars and cremastic. He was again talking from plantars to cremastic and abdomen, not talking about it. So the way the student should learn is to always not to miss anything, should start from above down. That's the best way of learning of a postgraduate.
Okay, sir.
Thank you.
Just to add to what Dr. Subramaniam sir asked, another like beautiful clinical point that we discussed already between upper motor neuron and LMN lesions is if the students have habit of reading Hutchinson's book now.
Clinical methods.
Yeah, clinical methods. That's a beautiful illustrative example of how a hemiplegic person ran when there was a fire accident, but could not move his limbs otherwise, right? So voluntary movements are significantly impaired, but involuntarily or reflexly they can have movements, good movements. So that is what you have shown actually. You said power is 0, but there is DTRs are exaggerated. So anti-gravity movements are present by doing reflex maneuver, but voluntarily they were not there. So that's another clue to upper motor neuron type of weakness.
Yes, sir.
That's excellent, sir. Actually, we love to hear from Ramesh Konagi, sir, always, because from my postgraduate level till now, I always learn some good points from him. Thank you, sir. And shall we go for the management? If there, like how to, you can ask the questions regarding how you manage this child and what are the.
Sure.
So, others, how you investigate this child? What are the baseline and first line investigation you advise for this child? And go ahead with sir.
Sir, any stroke, sir, any hemiplegia we should think of stroke and we should get a neuroimaging done immediately, sir.
Okay. What neuroimaging? CT scan, MRI? What do you want to do?
MRI with sir, MRI would be the best diagnostic image,
Okay.
neuroimaging.
Okay. Only MRI or anything else?
Sir, MRI with MRI.
That's what we say. Excuse me.
Yes, sir.
Excuse me.
Yes,
That's a student should not jump and say MRI. A consultant can talk. A student should never talk because the differential diagnosis and history, you are telling many things, but you are not planning to screen for any of them. You are telling about puffiness and bladder, bowel, everything. A simple urine examination can reveal many diseases. Simple blood picture can reveal many diseases, like as you said, sickle cell anemia and other things. These are the preliminary investigations done in the bedside and in the hospital. Should be talked first by a postgraduate. A consultant can, in a corporate hospital, can say MRI to be done. So students should never jump and say imaging first. That's what you should learn.
Yes, sir. Absolutely, sir. And when you say any investigation, you should explain why you want to do that. So you should maybe start with a complete blood picture, including peripheral smear, to look for any anemia, iron deficiency anemia features, to look for any features of sickle cell. So you should say, you should justify why you are doing it.
Yes, sir.
Even simple urine simple urine examination can reveal anything. Acute glomerulonephritis can present with acute encephalopathy. Hypertension encephalopathy can present with CNS disorders. But if you not use the urine examination, you may miss even that also.
Correct.
Yes.
So that is to be done. Even sugar can be detected in urine examination, but even nephrotic syndrome he was talking can be detected in urine examination. These are the things which to be done. Hematuria can be detected in urine examination. A non-invasive procedure like urine to be talked first by any and every student.
Yes.
Thank you.
Yes.
Okay, please go ahead, please.
Yes. Yes, sir. Sir, we will do routine like complete blood picture with peripheral blood smear, sir. to look for any anemias and any. Then we'll look for. We'll do cardiac screening, sir. In this child, you'll get an ECG done and we'll get 2D echo done, sir.
Serum electrolytes, it shows how what is the sodium levels and which can cause many CNS problems. Even random blood sugar, which can reveal many things. So
Yes,
these
sir.
are, don't miss any of the common investigations done in our any and every setup.
Yes, sir.
Okay, please go ahead.
So after blood, what else you want to do, others? Like you set up the blood. Do you want to do anything else in blood to rule out any blood disorders? You said only CBP with the peripheral smear. Do you want to add anything else?
Sir, if we are not finding any diagnosis in this, then we'll think of inherited or acquired.
Yeah.
This. Yes, sir. Hello. Sir,
Then we
we'll think inherited or acquired prothrombic state disorder, sir. So
Okay.
we'll send protein C levels, protein S levels, and plasma homocysteine levels.
Okay. So what? Yes, sir, Ramesh sir.
Yeah, I think so. Whenever you talk of management, one you delineate, okay, to confirm the vascular nature of neurological problem. I want to do this test. Okay, do this in neuroimaging. Then
Yes,
to
sir.
look, so once you confirm that it is vascular in nature, and if it is ischemic stroke, then I look for these things. Again, there are a lot of investigations that can be done. Starting from simple complete blood picture to genetic testing. So you have to say which are the tests that you would want to do in all children with stroke. And then the second line, third line test may depending on the first line investigations. So
Yes,
as
sir.
Sriram Redser said, all children with ischemic stroke should you should have done a complete blood picture, a sickling screening, right? And
Yes,
a complete urinary examination, a 2D echo. So these are the simple investigations which all children should, ischemic stroke should have got already.
Yes, sir.
The second line investigations, where if you don't get any cause in the first line test, then you can go for second line tests. There are prothrombotic screening tests, metabolic screening tests, genetic tests. So those will be level 2 and level 3.
Yes, sir.
So don't club them and say it as a list again.
Yes, sir.
Okay. Yeah. So one part is investigating, the parallelly other part is management also, treatment also. So you should talk of when you're asked to asked how do you manage this patient. So one is investigating in a systematic manner from simple investigations to more complex tests, and
Yes, sir.
the treatment also from basic things like care of airway, breathing, circulation, depending on the sickness and urgency of the clinical condition, and then
Yes.
more specific treatment modalities. Okay.
Yes. Yes, sir. Initially, we'll look for stabilization and supportive care, sir. We'll take care of airway, breathing, circulation.
Okay.
Then, based on any like life-threatening events, if there is any raised ICT, we have to treat raised ICT. If there are any seizures, we have to treat seizures.
So symptomatic and supportive care and definitive treatment. So you should divide your management like that.
Yes, sir.
So what will be the definitive treatment in this child other than supportive care that you mentioned and symptomatic? If there is any hyperthermia, hypoglycemia, hyponatremia, those things you will treat. What is the definitive management if it is a arterial stroke?
Sir, based on the cause, sir, if it is sickle cell anemia, then we have to give blood transfusion. You have to hydrate the child.
Hydration is most important.
Yes, sir.
Every child should be hydrated well.
Sir, anticoagulants. We will start.
Sriram Reddy, sir, are the postgraduates are expected to know these things, or can we stop at that level, sir?
No, it's really what we do is we not go beyond this.
Yes.
To be frank,
Okay, sure, sir. That's what I know.
But I want, yes, sir. I'm sorry to interrupt.
No.
But I want to elaborate, Ramesh Konagi, sir. How do you manage, like, if the case of stroke
No,
comes?
we want to know it. No, definitely we want to know. When sir asked me that what level of extension you will go in the postgraduate teaching, I was telling. But here we want to know it exactly what to be done.
Sir.
What to be done, really. Sir, I was telling, what we do is, for example, he said when there is a raised ICT, we immediately put a question, what are the signs of raised ICT? That's the way how we'll teach to the postgraduates, sir. No, because management, to be frank, we talk very less about management. About part one, just 1 to 2 minutes we'll talk. But when they talk about raised ICT, for example, I'm telling, sir. So just can you tell 3 or 4 points to say these are the signs of raised ICT? Like that we ask, sir.
Yes.
Babu, can you tell others what are the signs of raised ICT?
Yes, sir. Sir, there could be headache, sir, vomiting, altered sensorium, bradycardia. There can be hypertension.
Bradycardia. What is the blood pressure?
Sir, hypertension. There can be hypertension, sir. Hyper.
What is the type of respiration you get it? It's like chain stroke.
Yes,
so, chain stroke type of respiration is expected. Ramesh sir, this is where management is equally important, because in future also they should know it, sir.
Yes.
Please go ahead, sir. Please go ahead.
Fine. Yes, sir. Same. Obviously, sir. Basically, if they don't know about the signs of intracranial hypertension and other basic things, obviously we can't go to the next level of management. Definitely, those are very, very important, and these are all clinical pointers. We are not talking of any high-end investigations to say. Absolutely, they are essential for them to know. I think the next, I think relevant question would be, what is the definitive treatment? If it is a arterial ischemic stroke. So mainly question is about thrombolysis, anticoagulation, and antiplatelet drugs. So as a thrombolysis is not a very well established or standard of care in pediatric age group. So thrombolysis is not an option unless in a clinical trial basis or a research basis as of today. The second thing is anticoagulation. Anticoagulation can be started in the acute phase till your workup is over and you identify a cause. So once you identify a cause, and if there is an indication for long-term anticoagulation, like there is a structural complex congenital heart disease where there is a source of embolus, which is a constant source, you may want to continue anticoagulation till that lesion is corrected. Or there is a carotid dissection, and embolus can form there as long as dissection is there, you will continue anticoagulation. So only in these rare situations, you will continue anticoagulation for a longer term. Otherwise, in most of the cases, the anticoagulation role is limited to acute phase only. Once your acute phase is over, you have done all the workup, you will only do what is called secondary prevention. So preventing another stroke by using antiplatelet drugs. That is the standard of care. The duration of antiplatelet drug will vary from case to case based on what is the likely cause. If you are thinking of a post-infective vasculitis, it may be shorter term for 3 to 6 months. If it is unknown cause, it may be for at least 1 year from the acute event. So like that. So from case to case basis, it can range from 3 months to 2 years or even longer. And if there is any definite reason, etiology identified, suppose there is a prothrombotic state identified, you will have to continue lifelong also sometimes.
Very nice.
Any comments from any of the participants?
Actually, this is the case of looking like a moya, sir. So child doesn't have any other previous history, maybe presented with the first episode of stroke. And cerebral angiogram is showing involvement of middle cerebral artery and little part of internal carotid even. But remaining all the investigation we did for a prothrombotic or nephrotic or cardiac and infective workup, everything came normal. So we, as you said, like we started on anticoagulation for the first 3 to 4 days. And once we got this, then we advised to take a lower dose of aspirin for a little longer with the help of the neurologist support.
Okay.
So that's what still we were not sure that because in Moya we see many vessels involved, but here is the only vessel which is more involved compared to the other. Maybe it's evolving type of disease. We're not sure about, sir. If you want to add any other points for this, the investigations what we get.
No, I think Moya is a radiological diagnosis mostly. So I think we will not go into minute details of Moya diagnosis. Maybe it is out of scope for postgraduate learning.
Post-graduation.
Yeah.
That's all.
So if there are no comments, suggestions from faculty, experts, and participants, we are coming to the end of this program.
Yes, sir. I just want to make a last comment for the trainees mainly. So many times the students are scared of neurology cases, but as you can see in the today's discussion, there is no discussion on any investigations or anything. It's all about basic skills of history taking, asking relevant questions, having knowledge of basic anatomy of neuraxis, and a skillful examination. This is all we expect from postgraduates. So although the discussion is less on the management, again, we don't want you to miss on basic aspects of management, basic skills of management. So that's all we expect. So these are the things which can be acquired by repeated case taking, presenting, and good honest examination. That's all.
Yes.
Thank you, sir. Thanks a lot for giving your time and teaching our post-graduation and giving this opportunity. I really thank Sunkoj Bhaskar, sir, for giving this opportunity. And thank you, Sriram Reddy, sir, for giving your time in spite of busy from Warangal. Thanks a lot.
Even actually, I didn't expect this, the way it went on, really amazing, exciting, very thrilling. And the luckiest person of this entire PG Clinics is none other than Dr. Adarsh.
Yes.
He had gone through such a wonderful passage, being guided and asked by the seniors like Dr. Sriram Reddy and Ramesh Konanki. I'm sure this is one of the few best. I cannot say the best because it hurts others. So to be a different person, it is one of the few best PG clinics we ever had in 2022. And the way Dr. Ramesh Konanki spoke is a very crispy, with clarity, relevant, very informative. Words are not sufficient to talk about him.
That's what, sir. I was saying my PG that when I saw that Ramesh Konanki sir name and Sriram Reddy sir, I told like, be ready, you're going to get roasted. So this is the place where, because he is in first year, sir, actually, he's a secondary DNB, joined recently. So I thought, let it be what you want to go ahead, please go ahead so that you'll learn a lot of points.
But he was encouraged. He was encouraged by seniors like Dr. Sriram Reddy sir, Dr. Ramesh Konanki sir. That's how they move with the
learn.
That's how they move. And amazingly, had it been a live in-person program, we would have asked for standing ovation to the experts.
That's true, sir.
That much they deserve. And I too learned so many things. Actually, I was supposed to go out on some other work, but I told to my wife, stay back, very useful, very interesting. So thank you very much. I'm thankful to the participants, including so many seniors are there. They were very interactive. And YouTube recording is available. I am going to forward this YouTube recording to all the groups, to all the members of IAPTC. Once again, my special thanks to Dr. Sriram sir, despite his batchmates of 70s are enjoying outside his hall. And Ramesh, sir, words are not sufficient to say my tribute to you. And
Thank you so much.
without his consent, I'm announcing the upcoming conference on December 10th and 11th. If he accepts, we have a 20 minutes presentation of recent concepts in febrile seizures by none other than Dr. Ramesh Konanki. I hope you will accept. If he accepts, he is there in the conference. I request you all to register for the conference and attend his lecture. So thank you, one and all, and wish you all a great, happy Sunday.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.